Thanks, Bob, for that presentation. Bob is joining us live for the Q&A session. And I have to say, we're really pleased that WellPath is part of our network. It's, I think, a real need for the entire healthcare system to make sure that a patient's medical record doesn't go dark when they are incarcerated. And as Bob said in his presentation, there are some frequent flyers, and so we're avoiding the checkerboard effect essentially by ensuring that clinical records are maintained within WISHN, and we're getting that data from WellPath while they're incarcerated. And so that's actually covering a hole in the network and the continuum of care, and that's really what we're about. I mentioned earlier this morning how hospices and home health agencies and local public health entities are somewhat on the fringe of sort of what you might consider the standard or normal sort of delivery system. I think the correctional health system is another example where sometimes it gets forgotten about, but it's very important to have a complete medical record, and we're really pleased that we're able to facilitate that. One of the things that we wanted to explore a little bit more deeply with Bob is the process and the obligation that WellPath has when there's a new inmate, when their first the intake happens, and what would the alternative be if WISHN weren't available? What would you have to do in that situation?
So, and that's what we've done since the beginning of this industry, is that assessment. And over time, that assessment has grown pretty large. That's a 10, 12 page assessment of subjective and objective measures, somatic, mental health. And then there's this whole back end process that goes on to validate that information once it's collected. So it's calling pharmacies to get medication history. It's calling outside medical doctors or whoever, clinics on the outside, to gather more information on the chronically ill or the mental health patients inside. So it's it's not labor intensive, but it's time sensitive. And if we can shorten that to minutes and hours instead of days, we certainly have a better opportunity to take care of that person.
Right. And I would imagine, based on what we know about the correctional population and the behavioral health population, there's a considerable amount of overlap. And one of the reasons why we're looking forward to adding the Milwaukee County Behavioral Health Division into our network. That seems like it would be a considerable shortcut for your folks, at least in Milwaukee County.
Yeah, the behavioral health is a ever increasing part of what we do, right? This population doesn't get healthcare generally on the outside, and especially not behavioral health on the outside. Just navigating our healthcare system is complicated for people. Navigating the payer system is complicated, and all of those services fall to the jail. All of those services fall to the jail to provide for that short window of time that they're in there. So we have discharge planners that plan and try to do transitions so that the chronically ill or the people with specialized conditions can get treatments on the outside. But historically, those records are faxed or, whatever. The HIE really has the opportunity to streamline that, cause that to be much more timely and much more complete. If the person doesn't go here but goes there, the record is available, when they seek treatment. That's beyond our control.
Right. I should also mention that WISHN is contracted with the Wisconsin Department of Corrections. So essentially the state prison system, and where you're dealing in Wisconsin is at the county level.
Right.
So we're covering that waterfront pretty well. One of the things I wanted to go back to, based on your presentation, was you had made mention of the single sign-on integration between Wish and Pulse and your system. We hear a lot from folks that they really need to stay in that workflow. Can you talk a little bit more about that, how important that is?
Oh, single sign-on is hugely important, right? I mean, it's one of our strategies as a business is that you have to remember one authentication, and now with multi-factor authentication hitting everybody, that is just another burden. And in our space, the lack of mobility, the cell phones, and kind of those tools we don't get to use in those facilities. Single sign-on, remembering one password, one set of dual-factor authentication gets us into the network and all the resources that the folks need. Again, simplicity, kind of usability, accessibility, all the good stuff that comes with that is a super important feature in any of the partners we have.
Thanks. Steve's monitoring the questions here, and so you have a couple.
Yeah, one question. Does WellPath feed Wishin to give line of sight to care provided while an individual is incarcerated for providers after release? And that aligns with one of my questions. And Joe mentioned it previously. There's some coordination of care to a state or federal penitentiary. How does that care information follow them or back into the community, as this question is getting at? So how do you see that coordination with the data that you send to Wishin?
So, I mean, that's a core part of what we do, and a core part of the value proposition here is that it's a complete record, right? That it's everything. So so all of those treatments, labs, pharmacy, whatever that's done inside is then pushed out to Wishin and is part of that 360 health record for these folks. And it is definitely part of the equation. And we've seen in other states where that's not the case, where you have these implementations that are grant funded or really just meant to be proof of concepts. And so the direction flows usually out from us to the community and not coming in. And, it's beneficial, but it's like, fighting a battle with one arm tied behind your back. You don't have everything. And it's certainly then it's not a complete record at that point.
Right. That gets to the reciprocal nature of health information exchange.
Right.
You give to get, you get to give, and everybody's on the same page. So are there other questions, Steve?
There is one more question. Which counties are currently live participating in today? Bob, if you want to answer that, and I can add some additional information to that.
Yeah, the big ones, Dane County, Milwaukee County certainly is, Waukesha. I think there's 4 or 5 we've got live, and we've got a couple more on the runway right now up in Eau Claire, and I think maybe Brown County.
Yeah. You did hit them. Milwaukee, Waukesha, Marathon, and Shawano, Eau Claire, and Dodge on the runway.
Gotcha.
So a recurring or common theme today in the question and answer segment, what kinds of data are most useful in that intake process for WellPath? If you had to boil it down to that information that's most useful at that time, and how the participants contributing data to Wishin understand the value of that in that receipt of that patient, but more so avoiding that query and fulfillment process that could be avoided.
Sure. That's a great question. And we wrestle with that in some areas, not with you all, but in some areas where the data set is limited, right? So it limits the value. Like the easy ones are, problem list and medications and maybe labs, right? Labs to help reduce redundancy and that, but medications and problems for sure. But it's really curious. One of the examples we use in ART presentations is an example of someone who is shot or injured during an arrest and goes to the hospital first before coming. And so, it's pretty interesting to see a medical record at intake where the person had a gunshot wound 4 hours earlier, and it's documented and it's in the HIE and it's available at intake. Under the previous system, we wouldn't know that. We wouldn't know that until they're doing a head-to-toe examination, which is maybe 10 or 14 days after incarceration. Say, what is that wound for? Right. Because they don't come in carrying a medical record in the police car, right, or in their pocket. So, like when we talk about limited data sets and the value of problems and medications, that's huge. But then these other things, and they're not very common, but when they happen, they're super helpful. And almost, I don't want to quote the numbers, but in some areas, there's a large percentage, 25% that have a drive-by at a hospital before they come to the jail, where there's an injury or something they're treated for. And the officer determines that it's at a level that they should go to the doctor first. And we're not aware of that person until they do that drive-through, right? And or go through an ER or something like that. And having that data is super then helpful because we can continue to treat, that therapy, whether it's wound care or whatever it is. It might be a behavioral health episode that occurred. And if they go to the ER and they're treated, and we learn from them that there was a behavioral health incident and there was violence, and that's what caused the hospitalization, we can go and get a behavioral health consult within hours of the incarceration.